We tend to focus on the major arteries and veins, right? The big highways for blood flow.
Yeah, absolutely.
But there's this whole other network, almost hidden, the lymphatic
Yeah.
system.
The unsung hero sometimes.
And what's really fascinating is how tightly it's connected to our vascular system,
Thanks for
especially when surgery's involved.
Exactly. I mean, vascular surgery, it's all about getting blood flow sorted.
Right.
But those lymphatic vessels and nodes, they're right there in the mix. So they can get affected, sometimes unintentionally.
So that's what we're diving into today. These potential lymphatic issues after vascular surgery.
Precisely. We're going to unpack those lymphatic complications that can sometimes pop up.
Okay. And we've been digging into some really detailed material, chapters from Rutherford's vascular surgery and endovascular therapy, the 10th edition.
That's right. Top-tier source.
So think of this as, well, your guide to understanding the key lymphatic things you might encounter post-surgery.
Yeah, our mission isn't to overwhelm you with jargon. It's more about shedding light on the common stuff, like, swelling,
Which we'll definitely get to.
and also some of the rarer but potentially more significant issues.
We just want you to feel informed, empowered, really, about your own vascular health journey.
Absolutely. So, should we jump in?
Let's do it. Where do we start?
Let's start with something that's actually surprisingly common. Leg swelling after a bypass in the lower leg. Infranquinal reconstruction.
Post-bypass edema.
That's the one. And when I say common, I mean really common. It can affect anywhere from 50%
Okay,
to literally 100% of patients.
Wow, 100%. So it's almost expected then.
Pretty much. It's something folks should probably anticipate, at least to some degree. That's really important to know up front.
Okay, 50 to 100%.
Yeah.
That's huge. So when does this swelling usually show up? And maybe more importantly for people, when does it go away?
Yeah, good question. You'll typically notice it more when you're up and about again.
Like when you start walking.
Exactly. When you resume your usual activities, it's pretty evident with dependency, like standing or sitting with your legs down.
Okay.
The good news is, for most people, this kind of swelling, the pitting edema.
Where you press it and it leaves a dent?
Yeah, that kind. It generally clears up within, say, 2 to 3 months.
Oh, okay. That's not too bad.
Usually. But, and this is important, in some cases, it can unfortunately be persistent. It can stick around longer.
Persistent swelling. Yeah, that doesn't sound like fun, especially after you've had surgery hoping to feel better.
No, definitely not.
So what's the underlying mechanism? Why does this actually happen?
Well, the core issue, it's really an imbalance.
An imbalance. Between what?
Between how much of this protein-rich fluid gets produced in the tissues.
Okay, the interstitial fluid.
Exactly. And the lymphatic system's ability, its capacity to actually drain that fluid away.
Oh, okay.
When that drainage system can't quite keep up, that's when you get the edema.
Got it. Too much fluid coming in or not enough going out. So what makes the lymphatic system struggle after the surgery?
Well, there are sort of two main things going on, two factors contributing to this lymphatic insufficiency.
Okay, what's the first one?
First, the surgery itself, if it's successful at restoring blood flow.
Which is the goal.
Right. That improved blood flow actually increases the amount of fluid filtering out into the tissues. So it increases the lymphatic load.
Ah, okay. So better circulation means more fluid for the lymphatics to handle.
You got it. It's like opening the floodgates a bit, more work for the drainage system.
Makes sense. And the second factor?
The second one, and this is often considered the more significant player,
Okay.
is a reduction in the lymphatic system's ability to transport that fluid.
How does that happen?
It happens because the lymph channels themselves can get injured or blocked during the surgery, especially in the areas where the surgeon's working, like the groin or behind the knee, the popliteal space, or even along the path where they might harvest the saphenous vein for the bypass graft.
So the delicate lymph vessels are just vulnerable during the procedure.
Exactly. Anywhere there's dissection, there's a risk of disrupting them.
So the surgery fixes the blood flow, but can inadvertently mess with the drainage. Is there good evidence pointing to lymphatic obstruction as the main culprit here?
Oh, absolutely. There's quite a bit. For instance, Eichhoff's experiments are really telling.
What do they show?
They showed that the local blood flow regulation, how the body adjusts blood flow, that actually gets back to normal pretty quickly, usually within about a week.
Okay, so blood flow sorts itself out fast.
Right, but the edema, the swelling, often hangs around for much longer.
Interesting.
Which strongly suggests it's not just about those initial changes in blood flow. Something else is going on.
Okay, so blood flow recovers, but the swelling persists. What else backs up the lymphatic damage idea?
Well, imaging studies lymphangiography.
Okay, where they look at the lymph vessels.
Exactly. Those studies consistently show fewer functioning superficial lymph vessels after a bypass.
How many fewer?
Significantly fewer. Like, on average, they found only about 1.7 working vessels.
Wow. Compared to?
Compared to a normal count of around 9.5.
Whoa. Okay. That's a massive drop.
It is. And what's really striking is that the edema was less severe when patients had more than 3 intact vessels left.
So the more vessels you save, the less swelling you get.
That seems to be the case. It really highlights the impact of that disruption.
No wonder swelling is so common then, with that kind of reduction.
Precisely. And there's more. Abarama and colleagues did a study looking specifically at surgical technique.
Oh, interesting. What did they find?
They found that when they used a sort of conventional dissection technique for the arteries,
Okay.
edema developed in a staggering 85% of patients.
85%?
Yeah. But when they used a very careful technique, really focused on preserving the lymphatics,
Right, being gentle.
the rate of edema dropped dramatically down to just 10%.
10%. From 85. That's incredible.
Isn't it? It just shows how much surgical technique matters for this specific complication. And their post-op imaging confirmed more normal lymphatics in the group with less swelling.
That really drives the point home about being careful with those lymphatics during surgery.
It does. And Parence's work adds to this too. They saw less edema when less dissection was needed overall.
Like comparing different types of grafts or locations.
Exactly. Less swelling with prosthetic grafts compared to vein grafts, which often need more dissection to harvest the vein.
Okay.
And less edema with bypasses ending above the knee compared to those going below the knee, which again involves more extensive work lower down.
It all points back to the amount of surgical disruption, doesn't it?
Seems that way. The extent of manipulation really seems linked to the risk.
And what about the fluid itself? Has anyone looked at, like, the protein content? Does that confirm lymphatic involvement?
Yes, absolutely. Studies looking at albumin clearance. Albumin is a key protein. Showed lower albumin in the bloodstream, but increased albumin in the fluid within the swollen limb.
Ah, so the protein is leaking out and getting stuck there.
Essentially, yes, especially after femoropopliteal bypasses. And interestingly, this increase was much higher than in patients who had airtoiliac grafts, higher up.
Which fits with the idea that edema is less common after those higher procedures.
Exactly. Probably because there's less disruption of the leg lymphatics. So yeah, that higher protein content in the leg fluid is another strong pointer towards a lymphatic problem.
So it's clear for arterial bypasses. What about other types of vascular surgery? You mentioned varicose veins earlier.
Right. Even with varicose vein surgery, especially if it involves dissection in the groin,
Okay.
there's a known risk of lymphedema or something called a lymphocele, which we'll get to.
Why is that?
Well, it's thought that some people with varicose veins might already have a bit of underlying lymphatic weakness or dysfunction.
Ah, so they may be more susceptible.
Potentially. So extra care is definitely needed during open vein surgery to protect those lymphatic channels.
Okay, that makes sense. Now, one more thing to rule out. What about blood clots? Venous thrombosis or DVT. Could that cause this kind of post-bypass swelling?
That's a really important question. It was definitely considered a possibility.
Because a clot could cause swelling, right?
It certainly could. But studies looking into this have actually found a pretty low rate of DVT in patients who develop this post-bypass edema.
Oh, really?
Yeah. One study, for example, confirmed normal venous blood flow in most patients with swelling after their bypass. And another found similar DVT rates in patients with and without edema after FemPop bypasses.
So while it's something to consider and rule out, it doesn't seem to be the main driver for most people.
Exactly. In most cases, DVT seems to play a minor role in this specific type of post-bypass swelling. The evidence points much more strongly towards lymphatic issues.
Okay, that's good to clarify. So if DVT isn't the usual cause, how do doctors tell the difference between this common post-bypass edema and, something else that needs urgent attention?
Right, the diagnosis. Well, initially, the myelezema often looks like that typical pitting ankle swelling,
Okay.
and it tends to get better if you elevate your leg and rest.
Right.
True lymphedema, though, often just affects one leg, And it can have some classic signs like swelling over the top of the foot, sometimes called a buffalo hump.
Buffalo hump.
And the toes might look kind of squared off.
Ah, interesting visual.
Yeah, but it's absolutely crucial to differentiate this from other things.
Like DVT, even if it's less common.
Definitely rule out DV2. Also, infection like cellulitis or even compartment syndrome, which is a surgical emergency.
So how do they rule those out?
Physical exam gives clues, and a duplex ultrasound is really useful for checking for DVT and signs of infection.
Okay. And if it's still not clear?
If the cause isn't obvious, then lymphoscintigraphy, that imaging test for the lymphatics, can be used to confirm that there's lymphatic dysfunction.
Got it. So once it's diagnosed as post-bypass edema or lymphedema, how is it managed? What helps?
For the milder cases, simple things often work: elevating the leg whenever possible, getting enough rest.
Okay.
Some surgeons even recommend strict bed rest initially, and making sure any underlying heart issues are well managed helps with fluid balance overall.
Right. What about more severe swelling?
For moderate to severe edema, the mainstay is compression. Initially, maybe compression wrapping until the incisions are healed up.
And
Then graduated compression stockings, usually around 30 to 40 millimilli-Hg strength.
Oh, those are the tight medical ones?
Yeah, they provide firm pressure.
Yeah.
But there's a caveat: if the bypass goes way down the leg, like to the ankle or foot arteries,
Okay.
you have to be careful not to compress the vein graft itself, especially if it's sitting just under the skin. So the compression needs to be tailored individually in those cases.
Right. Don't want to squeeze the new bypass.
Oh, exactly.
What about medications? Do things like water pills or steroids help?
You know, it's interesting, but studies haven't really shown they are. Using surgical loops, those magnifying glasses surgeons wear, can make a big difference in actually identifying and preserving the delicate lymph vessels.
Makes sense.
And if a lymphatic channel has to be divided, it should be carefully tied off or cauterized to prevent leaks.
Right.
Also, trying to preserve the fatty lymphatic tissue that sits between where the saphenous vein joins the femoral vein and the femoral artery itself is important.
It sounds like it requires a lot of awareness and careful handling.
It really does.
Are there newer techniques helping with this? You mentioned vein harvesting?
Yes. Instead of one long incision to get the saphenous vein, using multiple short skin incisions.
Okay.
Or even better, endoscopic vein harvesting, where they use a small camera and instruments through tiny holes.
Right, minimally invasive.
Exactly. Those techniques seem to disrupt fewer of the superficial lymphatics running near the vein.
And studies back that up.
Yes, studies have confirmed that endoscopic harvesting can lead to fewer lymphatic complications. And as a bonus, potentially fewer wound infections too.
That's great. What about dissection deeper down, like behind the knee?
Same principles apply. Careful dissection around the popliteal artery, opening its sheath longitudinally, trying to leave the surrounding fatty tissue, which contains deeper lymphatics, as undisturbed as possible.
And what about avoiding open surgery altogether?
Well, that's another angle. Endovascular procedures, the ones done with catheters from inside the vessel, inherently involve much less dissection.
So less risk of lymphatic injury.
Generally, yes. And even when open surgery is needed, using minimal incision techniques to expose the femoral artery, when feasible, could also reduce lymphatic problems.
It seems like there's a growing focus on minimizing this collateral damage, so to speak.
There definitely is. And there's even some research exploring things like mapping the lymphatics before surgery with lymphoscintigraphy or using blue dye during surgery to see them better.
Wow.
Sometimes even creating tiny connections between lymph vessels and veins proactively during venous surgery to try and head off problems.
Fascinating. Okay, so that covers swelling pretty thoroughly. Let's shift gears. What happens if a lymphatic vessel isn't just blocked or overwhelmed, but actually gets cut and starts leaking?
Yeah.
You mentioned fistulas.
Right. A lymphatic fistula, that's essentially an active leak of lymphatic fluid from the surgical site.
Like a dripping pipe.
Kind of, yeah. And given how many lymph vessels are packed into the groin area, the femoral triangle,
Right.
that's the most common spot to see these fistulae after vascular reconstruction there.
Okay. And how often does this happen? Is it common like the edema?
Thankfully, no, it's less common than the edema. Incidence varies in different reports, but it's generally somewhere between, say, 0.1% and maybe up to 6.4%.
Okay, so not rare, but not happening to everyone.
Exactly. Something surgeons definitely need to watch for, though.
What causes these leaks to happen? Is it just not tying off a vessel properly?
That's a primary cause: failure to ligate or cauterize a divided lymphatic channel.
Yeah.
Also, if the tissue layers aren't closed properly, that can contribute. Other factors can play a role, too.
Like what?
Things like poor wound healing, which you might see more in older patients or those with diabetes.
Right.
Too much limb movement too early after surgery. Infection can be a factor. Having repeat surgery in the same area.
Makes sense. More scar tissue, harder dissection.
Right. And using a prosthetic graft in the groin might also increase the risk slightly.
So how would you know if you had one? What are the signs?
The most obvious sign is just persistent drainage from the groin incision. It's typically clear or maybe yellowish fluid, the lymph fluid itself.
Okay. Does it need special tests?
If it happens right after surgery, usually the drainage itself is diagnostic. You don't typically need lymphoscintigraphy then.
But what if it happens later?
Ah, good point. If a leak develops months or even years down the line.
Which can happen.
It can, though it's less common. In that case, lymphoscintigraphy can be useful to confirm it is lymph.
Okay.
And crucially, for those late leaks, you absolutely need to rule out an infection involving the vascular graft underneath.
Right. That would be serious.
Very. So that often involves things like CT scans, maybe with tagged white blood cells to look for inflammation, or sometimes fistulography injecting dye into the leak tract to see where it goes. CT can also check for related issues deeper in the retroperitoneum.
Okay. So once it's identified, how do you fix a lymphatic fistula?
Early diagnosis and getting on top of it quickly is important. You want to avoid prolonged hospital stays, slow healing, and that potential, though rare, risk of graft infection.
So what's the first step? Is it always surgery?
Not necessarily. Initial management is often conservative.
Meaning?
Things like careful local wound care, maybe systemic antibiotics just to prevent infection, bed rest, and keeping the leg elevated.
Why elevation?
Elevating the leg helps reduce the amount of lymph flow, hopefully allowing the leak to seal itself.
And how long do you try that for?
The aim is usually for the leakage to stop within about 7 to 12 days with these conservative measures.
Okay. And if it keeps leaking heavily after that?
If it's a persistent, high-volume leak, then yes, surgical repair in the operating room is usually the next step.
How do they find the tiny leak during surgery?
A common technique is to inject a special blue dye, isosulfan blue, into the foot about 30 to 60 minutes before the operation.
So it stains the lymph fluid blue.
Exactly. When the surgeon reopens the area, they can look for the blue-tinged fluid pinpointing the site of the leak.
Clever.
Then they can oversew it, stitch it closed. After that, the wound is closed carefully in layers.
What if they can't see the blue dye clearly?
If the dye doesn't clearly show the spot, they'll meticulously irrigate the area and close it anyway. Sometimes, if direct stitching is tough, they might use fibrin glue, like a biological sealant, to help stop the leak.
Okay. Any other options?
Interestingly, vacuum-assisted closure, or VAC therapy.
The wound VAC.
Yeah, that's shown some promise as well, particularly for fistulae that leak right onto the skin surface and for generally difficult wounds in that area.
Good to have alternatives.
Yeah.
Now, you mentioned lymphocele earlier, distinguishing them from fistulas. Can we talk about those? What's a groin lymphocele?
Right. So unlike a fistula, which is an open leak, a lymphocele is a collection of lymph fluid that gets trapped between tissue layers.
Okay, so it's contained.
Usually, yes. If the fluid isn't reabsorbed by the body or drained away, it can form a sort of pseudocapsule around itself.
Like a cyst filled with lymph.
Pretty much. And lymphoscintigraphy can often show a connection between this collection and the lymphatic channels. So maybe think of a fistula as a leak out and a lymphocele as a contained pocket.
Yeah, that helps clarify it.
Mm-hmm.
When do these lymphocele typically show up?
Often within the first month after surgery.
And what symptoms would someone notice?
It can cause local discomfort or pain in the groin, and sometimes leg swelling too.
Could it be mistaken for something else?
Definitely. You need to differentiate it from a hematoma, a collection of blood,
Right.
or a seroma, which is a collection of clear non-lymphatic fluid, or, of course, a wound infection.
So how do doctors tell them apart?
Well, feeling it, it's often a soft, fluid-filled cyst. Sometimes there might be a little intermittent drainage of clear lymph from a small skin opening.
Okay.
Ultrasound is very helpful here. It can easily distinguish a fluid-filled lymphocele from a more solid hematoma.
What about CT scans?
CT is particularly useful if the lymphocele develops later on. It helps rule out an underlying graft infection or check if there's a connection to a deeper lymphocele in the retroperitoneum extending down.
Okay. And the treatment for a groin lymphocele, does it always need intervention?
Not always. If it's small and not causing any symptoms, just observing it is often reasonable. They can sometimes resolve on their own.
But if it's big or causing problems?
Then intervention is usually needed, especially if it's getting bigger, causing pain, or if it's located near a prosthetic graft.
Because of infection risk near the graft.
Exactly. In those cases, early surgery is often recommended.
Similar surgery to the fistula repair.
Similar approach. They might use the blue dye again to find the feeding lymphatic channels. The lymphocell sac is then removed or excised, and the vessel leading into it is tied off or sewn shut. Then a careful layered closure, often with a drain left in temporarily to prevent fluid reaccumulating.
Are there non-surgical options for lymphocytes?
Yes, sclerotherapy is an option.
What's that?
That involves injecting a substance like doxycycline or alcohol into the lymphocell cavity. The goal is to irritate the lining and cause it to smar down and close off. It's used more often for deeper retroperitoneal lymphocytes, but it can be an option for groin ones too.
Interesting. Any other approaches?
For persistent problems with lymphedema and maybe recurrent lymphoceles, sometimes highly specialized microsurgery is done to create new drainage pathways, connecting tiny lymph vessels directly to small veins, lymphovenous anastomosis.
Wow, intricate work.
Very. And another surgical technique involves using a flap of nearby muscle, like from the groin, to fill the space where the lymphocell was. This can help obliterate the dead space and potentially provide some new lymphatic drainage pathways too.
Quite a few options depending on the situation. Now, you mentioned retroperitoneal lymphocytes, those deeper ones. Tell us about those.
Right, so this is a collection of lymph fluid, but it's happening deeper inside. In the retroperitoneum, that space behind the main abdominal cavity where the aorta and vena cava run.
Are these common after typical aortic surgery?
Actually, they're considered pretty rare after standard aortic reconstruction, like maybe 0.1% reported.
Oh, okay.
But they are seen quite a bit more frequently after kidney transplants.
Really? Why the difference? What happens in transplants?
It seems to be a combination of factors in transplant patients. There's potential injury to the recipient's own pelvic lymphatics during the surgery to place the kidney.
Okay.
But also, the transplanted kidney itself can produce a fair amount of lymph fluid, especially initially, and if that leaks out, it can collect.
So two sources of potential problems there. What kind of symptoms would a retroperitoneal lymphocell cause? Being deeper, I guess it's not as obvious.
Exactly. Symptoms can be more vague initially. Things like abdominal bloating or distension, maybe some nausea or abdominal pain. Sometimes a mass can be felt in the abdomen or the flank area.
When do these tend to appear?
It varies. They can show up relatively soon after surgery, but interestingly, in almost half the cases, they're not actually found until a year or even several years later.
Years later, wow.
Yeah. And sometimes a patient might present with a groin mass, which turns out to be connected to a deeper retroperitoneal collection.
So how are these diagnosed if they're hidden away back there?
CT scanning is really the key diagnostic tool.
Okay.
Especially if someone develops a groin issue after an aortofemoral bypass, a CT is essential to see if there's a communicating collection higher up.
What about infection? Same concerns as with groin lymphocytes.
Yes, absolutely need to rule out infection, especially if a graft is nearby. A white blood cell scan might be used if infection is suspected, unless the CT already clearly shows signs of graft infection. Lymphoscintigraphy can also help confirm its lymph fluid, differentiating it from maybe just fluid around the graft, but it doesn't rule out infection by itself.
And how are these managed? Is it similar to groin lymphocytes?
The principles are similar. Small, asymptomatic ones found incidentally might just be watched with follow-up imaging. If they're getting larger or causing symptoms by pressing on things, then needle aspiration is often the first step.
Guided by CT or ultrasound?
Exactly. That can drain the fluid, relieve symptoms, and confirm its lymph. Sometimes aspiration alone can be curative, but often they refill.
What about leaving a drain in?
Placing long-term indwelling grains carries a significant risk of introducing infection, so that's generally avoided if possible.
So if aspiration doesn't work?
Then you consider either sclerotherapy, injecting that scarring agent, or surgical repair. Surgery might involve using the blue dye again to find the leak, then opening up the lymphocell sac, unroofing it, and over-sewing or ligating the leaking lymphatic vessel.
And protecting the graft.
Absolutely crucial. If a prosthetic graft is exposed during the repair, it needs to be covered, usually with nearby retroperitoneal tissue or by bringing down a piece of omentum, that fatty apron in the abdomen.
What about the transplant-related ones? Any specific approaches there?
Yes, for post-transplant lymphoceles, a common and often preferred surgical approach is peritoneal fenestration.
Fenestration, like making a window.
Exactly. They create an opening between the lymphocell cavity and the main peritoneal cavity. This allows the lymph fluid to drain into the abdomen where the peritoneum can absorb it.
Can that be done minimally invasively?
Yes, it's often done laparoscopically now using small incisions and a camera. That usually means a shorter hospital stay, quicker recovery, and fewer recurrences compared to open surgery.
And sclerotherapy is also an option for these.
It is. Percutaneous sclerotherapy, using various agents like talc, bleomycin, povidone iodine, or alcohol, is being used more and more successfully, although sometimes repeat injections are needed.
Okay, that covers localized collections. Let's move to something more widespread. Chylous ascites. What exactly is that?
Chylous ascites is when chyle accumulates inside the abdominal cavity, the peritoneal space.
And chyle is?
Chyle is that milky fluid we talked about earlier. It's basically lymph fluid that's rich in fats, specifically triglycerides absorbed from the intestines and also proteins. It normally travels through the lymphatic vessels in the abdomen and eventually reaches the bloodstream via the thoracic duct.
So, in chylous ascites, this chyle is leaking out into the abdominal cavity instead.
Exactly. It's pooling there.
Is this common after aortic surgery?
No, thankfully it's considered a rare complication after abdominal aortic reconstruction. But when it does happen, it's a significant problem. It can cause major morbidity, meaning illness, and unfortunately, even mortality.
Why is it so serious?
Because you're losing large amounts of fat, protein, and lymphocytes into this abdominal fluid collection.
Okay, leading to nutritional problems.
Yes, significant malnutrition, protein depletion. Also, the loss of lymphocytes can impair immune function, making patients more prone to infection. Plus, the fluid buildup itself causes problems.
When does it usually show up?
Typically within the first 6 weeks or so after the surgery.
And what are the signs and symptoms someone would experience?
It often presents with progressive abdominal pain, maybe shortness of breath because the fluid pushes up on the diaphragm,
Right.
nausea, and just significant abdominal swelling or distension. You might also see signs of the malnutrition, weight loss, muscle wasting, low protein levels in the blood, low lymphocyte counts, maybe anemia.
That does sound quite severe. How is it diagnosed definitively?
Physical exam will often reveal the ascites, the fluid buildup. Ultrasound or CT confirms the fluid is there.
Okay.
But the key is paracentesis, putting a needle into the abdomen to get a sample of the fluid.
In analyzing the fluid?
Yes, you analyze it to confirm it's actually chyle. It usually looks milky or creamy.
That milky appearance again.
Right. It's typically odorless, sterile, alkaline. Lab tests will show specific characteristics: specific gravity over 1.012, high protein over 3 GDL, high fat, usually 0.4 to 4 GDL, and it stains positive for fat with Sudan stain.
Got it. So once it's confirmed, what's the treatment approach? Is it always surgery?
Not always. The prognosis for chylous ascites after aortic surgery is generally a bit better than when it's caused by something like malignancy, and non-operative management is often successful, especially for milder cases.
What does non-operative involve?
The main goal is to reduce the flow of chyle. For mild to moderate cases, this often involves dietary changes. Specifically, a diet low in long-chain fats and high in medium-chain triglycerides, or MCTs.
Why MCTs?
Because MCTs are absorbed directly into the portal blood system, bypassing the intestinal lymphatics so they don't contribute to chyle formation.
Ah, clever. What about more severe cases?
For severe chylous ascites, the patient might need complete bowel rest, nothing by mouth, and get all their nutrition intravenously through TPN, total parenteral nutrition.
Okay.
Repeated paracentesis, draining the fluid, can help relieve symptoms like abdominal pressure and difficulty breathing, but it doesn't fix the underlying leak and contributes to nutrient loss.
Any other non-surgical options?
A peritoneovenous shunt, a tube placed surgically to drain the ascites fluid from the abdomen into a large vein, has been used, but it carries a significant risk of complications like infection and shunt blockage, so it's not usually a first choice.
So if these conservative measures don't work,
Then surgical exploration is usually necessary to find and stop the leak.
how do they find the leak during surgery? It must be small.
It can be tricky. Sometimes giving the patient a fatty meal like cream a few hours before surgery can help. It stimulates chyle flow, making the leaking point potentially easier to see milky fluid weeping from a specific area.
Okay. And then what do they do?
The surgeon meticulously explores the retroperitoneum and the base of the mesentery, looking for the leak. Once found, the leaking lymphatic vessel or plexus is ligated, tied off, or oversewn with fine sutures. Sometimes fibrin glue is used as well.
Is laparoscopy used here too?
Yes, laparoscopic techniques are emerging for this as well. Surgeons can use clips, electrocautery, or fibrin glue to seal the leak through small incisions. Often, medications like somatostatin or its analog octreotide are used alongside surgery as they can help reduce splanchnic blood flow and lymphatic output. A low-fat diet is usually continued post-operatively too.
Makes sense. How can surgeons try to prevent this from happening in the first place during the initial aortic surgery?
Prevention really comes down to meticulous surgical technique and awareness of the lymphatic anatomy back there.
Okay.
Avoiding unnecessary injury to the retroperitoneal lymphatics and the lymph vessels around the root of the mesentery during the aortic dissection is crucial.
What about specific structures to watch out for?
Surgeons need to be aware of the potential location of the cisterna chyli.
The start of the thoracic duct.
Right. It's typically around the L2 vertebra level, often sitting between the vena cava and the aorta. But it's variable, and it's actually absent in about half of people.
Okay.
There are also some large lymphatic channels near the left renal vein that are particularly vulnerable during dissection in that area.
So what's the practice if lymphatics are injured or need to be divided?
If large lumbar, para-aortic, or mesenteric lymphatic vessels have to be divided, they should be carefully ligated with sutures or clips to prevent leakage. If the cisterna chyli itself is inadvertently injured, a careful attempt should be made to close it laterally with fine, non-absorbable sutures.
Okay, so careful dissection and ligation are key. Let's move up the body now. What about lymphatic issues higher up, like in the neck or chest? You mentioned the thoracic duct. Can that be injured?
Yes, the thoracic duct itself, which is the main lymphatic channel collecting lymph for most of the body, can be injured during surgery in the neck or upper chest.
What kind of surgeries carry that risk?
Typically dissections involving the base of the neck and superior mediastinum. For vascular surgeons, this might happen during exposure of the proximal left common carotid artery, the left subclavian artery, or the vertebral artery.
And if the thoracic duct is injured and leaks, what are the consequences? Is it similar to chylocystitis?
It leads to a leak of chyle, yes. But instead of pooling in the abdomen, it leaks into the surrounding tissues or potentially out through the wound, forming a thoracic duct fistula.
What happens if it's missed or neglected?
Similar problems to chylocystitis due to the loss of nutrients and immune cells, malnutrition, lymphocytopenia, low lymphocytes, anemia. And if there's a prosthetic graft nearby, like for the subclavian or carotid artery, there's a risk of graft infection.
So what's the best way to treat a thoracic duct fistula if it occurs?
The optimal treatment is usually early surgical repair. Ideally, direct closure of the hole in the duct with very fine non-absorbable sutures like 7-AIR or 8-AIR.
Well, if direct repair isn't possible?
If direct closure can't be done, then ligation tying off the thoracic duct at the site of injury in the neck is an acceptable alternative.
Does tying off the main duct cause problems?
Usually not, because there's typically enough collateral lymphatic circulation that develops to handle the drainage from the lower body. After the repair, a small subcutaneous drain is often left in for a short time just to monitor for any residual leak.
Okay. And related to the thoracic duct, what about chylothorax? Chyle in the chest cavity.
Right. Chylothorax is when chyle leaks into the pleural space, the space between the lung and the chest wall.
How common is this after vascular procedures?
It's generally uncommon, maybe seen in 0.2% to 1% of cardiothoracic surgeries. It can occasionally happen after repair of thoracic or even high abdominal aortic aneurysms, or procedures like dorsal sympathectomy, or even historically after high translumbar aortography. It's actually more common in newborns with certain congenital vascular problems.
How is chylothorax diagnosed? Is it obvious?
A standard chest X-ray or a CT scan will show the pleural effusion, the fluid buildup in the chest. The diagnosis is confirmed by thoracentesis, drawing off some of that fluid.
And looking for chyle.
Exactly. Analyzing the pleural fluid. It might look milky, but actually less than half the time it does.
Oh, really? So appearance isn't always reliable?
Not always, but lab analysis is key. The fluid is typically rich in albumin and lipids. The diagnostic criteria usually include triglyceride levels greater than 110 milli-GDL, often a milky appearance that might separate into a creamy layer on standing, odorless, specific gravity over 1.012. CT scans can also help rule out other causes like malignancy, and sometimes MRI might show dilated lymphatic channels. Lymphangiography is rarely needed just for diagnosis.
And how is chylothorax managed? Is it similar to chylocystitis?
The principles of reducing chyle flow are the same.
Yeah.
Low-fat diet, MCTs, possibly TPN for severe or persistent leaks.
Okay. But what about the fluid in the chest?
That usually needs to be drained. A chest tube or thoracostomy tube is typically inserted to drain the chyle, allow the lung to re-expand, and monitor the amount of ongoing leakage.
Does the leak usually stop on its own with drainage and diet?
It can, but if the output from the chest tube remains high, say over 1,000 milliliters per day in an adult, or persists for more than a week or two despite conservative measures, then surgical intervention is usually considered.
What does surgery involve?
The goal is to ligate, or tie off, the thoracic duct. This is typically done low in the chest, just above the diaphragm, as it enters the thorax.
Can this be done minimally invasively too?
Yes. VATS, video-assisted thoracoscopic surgery, is increasingly the preferred approach. It allows the surgeon to find and clip or ligate the duct through small incisions.
Is it always easy to find the duct?
Not always. If the duct itself isn't easily identified, surgeons might ligate the bundle of tissue that lies between the azygos vein and the aorta in the right chest, as the duct usually runs within that tissue plane.
Are there other options besides ligation?
Yes, sometimes pleurodesis is performed. That's where an irritant substance is introduced into the pleural space to cause inflammation and scarring, essentially sticking the lung to the chest wall and obliterating the space where fluid can collect. Rarely, if a specific leak can't be found and pleurodesis fails, a parietal pleurectomy, stripping the lining of the chest wall, might be done. Also, percutaneous embolization of the thoracic duct by interventional radiologists is emerging as another alternative treatment.
So quite a few options there too. Early surgery is sometimes recommended for high output leaks.
Yes, because prolonged conservative management with high output leads to significant nutritional depletion and immunosuppression. So, many surgeons advocate for earlier VTESIUS ligation if the chest tube output is high, say over 1,000 millidae, or remains significant, like over 200 millidae, after about a week of conservative therapy to avoid that long, debilitating course.
And prevention. How can surgeons avoid injuring the thoracic duct during chest surgery?
Again, it comes down to careful technique and anatomical awareness. Knowing the typical course of the thoracic duct starting from the cisterna chyli in the abdomen, ascending usually on the right side of the aorta in the posterior chest, then crossing over to the left, higher up in the superior mediastinum, before emptying into the venous system near the left subclavian vein, is crucial during any dissection in those areas, especially during thoracic aortic surgery.
And if an injury is noticed during the operation?
If an injury is recognized intraoperatively, an attempt should be made to repair it directly with fine sutures, using magnification. If direct repair isn't feasible or secure, then ligation of the duct at that point is the best approach, relying on those collateral pathways to develop. So if we wrap this all up, it's clear that while vascular surgery is focused on fixing the pipes of the circulatory system,
The arteries and veins.
right, we absolutely have to remember that other intricate network, the lymphatic system, running right alongside it.
Yeah. And as we've really unpacked today, disruptions to that system can lead to a whole range of issues.
Exactly, from the very common leg swelling after bypass
That post-bypass edema affecting so many people.
to those less frequent but potentially very serious complications like fistulas, lymphoceles, chylocystitis, and chylothorax.
Understanding these possibilities, even the rare ones, is just so important, isn't it? For anyone going through vascular procedures or managing their recovery, it gives a much more complete picture.
Absolutely. It empowers you with a better perspective on your vascular health and what the recovery journey might involve.
It really makes you think about the interconnectedness of it all.
It does. And, it raises a really interesting question for the future, perhaps. Given how closely linked these two systems, circulatory and lymphatic, truly are,
Yeah.
what other subtle interactions might we still be overlooking? Are there other ways these systems influence each other, especially in disease states or after interventions, that we haven't fully appreciated yet?
That's a fascinating thought. Exploring those deeper connections could maybe lead to even better ways to manage vascular health down the road.
Perhaps. It's certainly something worth considering as we continue to learn more about these complex systems within us.